by the end of today's presentation, you should be able to know what auto-EPAP is and what target volume is. You should be able to identify when auto-EPAP and target volume modes may be useful, to understand how to initiate these modes, and explain why some patients and some centres benefit from using auto-EPAP and target volume, either as standalone modalities or in conjunction. So let's start by looking at when to provide ventilatory support. And it's always best to go back and look at the respiratory muscle pump. Now, in health, there is equilibrium between the capacity of the respiratory muscles and the load placed upon them, and central drive is intact. However, in disease, what happens is you may find that there is a disorder of central drive, which means that the impulses to the respiratory muscles are not sent, and therefore there is periods of pauses in breathing. You may also find that the load placed upon the respiratory muscles exceeds the capacity, and this can occur in diseases such as COPD or obesity. And of course, there is also the problem of the capacity of the respiratory muscles may be affected in conditions such as neuromuscular weakness. And the treatment for this is simply to provide ventilatory support to offload the work of breathing and the work required by the respiratory muscles, and in some situations to set a backup rate to overcome issues with central drive. When we look at ventilation modes, historically, non-invasive ventilatory support started with volume cycled ventilation, and that is typically not really used as much anymore. We have mouthpiece ventilation, which I believe is underutilised and can be a very useful tool, and that's not the topic of today's lecture. We have preset pressure ventilation in the form of spontaneous timed pressure support ventilation and pressure control ventilation. And then we have target volume modes, which are called different things by different manufacturers, but consist of target volume, IVAPs and AVAPs. And with these modes, we're now able to add either in conjunction with the pressure support or the target volume modes auto-EPAP. So how do we provide ventilatory support? Well, when I see my patient, I can look at them and I think, well, do I want to provide standard pressure support, or does this patient need target volume? Or do they need pressure support or target volume in conjunction with auto-EPAP? Let's take a moment to look at the differences between standard pressure support and target volume. So you'll all have seen this before, but when we look at standard pressure support, the ventilator will cycle between two pressures. We have the inspiratory positive airways pressure, and for the purpose of this diagram, it's set at 15 centimetres of water. As clinicians, we deliver as much pressure as needed to have an adequate rise and fall of the chest wall and provide adequate ventilation for the patient. We then have our expiratory positive airways pressure. And in a leak circuit, this is set to a minimum of 4 centimetres of water to flush out the dead space, but can be higher if we are treating upper airway collapse, intrinsic PEEP, or atelectic areas when we're trying to improve oxygenation. Of course, we have other parameters. Some ventilators have the ability to set a set inspiratory time, whilst others you may set an inspiratory window between a TI max and a TI min. And we can also adjust our rise time to look at how the breath goes in. But each breath will be fixed between a set IPAP and a set EPAP. And here we have, if we look at the difference between our IPAP and our EPAP, we have a pressure support of 10 centimetres of water. Now, first of all, I'm going to describe what happens with the IVAPS algorithm. I'm just going to take a moment to bring up my laser pointer so we can see where I am. So with IVAPS, we set a target alveolar ventilation, and this this algorithm will exclude the anatomical dead space, so it's taken that into account. With the device, you set your patient's height and it will work out what the alveolar ventilation needs to be. What the device will do is it will set that target, which you can see here in the black dotted line. The device will then measure what actually happens to the alveolar ventilation, and it will adjust the pressure support accordingly. And you can see at this point, our target alveolar ventilation is here, and our actual alveolar ventilation is lower than our target. So the device increases the pressure support. Now, it may be that we don't need to have that pressure support so high for all of the time. So what happens in the event of our actual alveolar ventilation being higher than our target ventilation, the pressure support decreases. We also have modes of target ventilation or average volume assured pressure support. And with these devices, it's no different. We set a target volume and the pressure will change depending on what is happening to our actual volumes between an IPAP min and an IPAP max, or a pressure support min and a pressure support max, depending on what device you're using, but basically the same thing. And so what we do is we set our target volume to be around 7 to 8 mils per kilo of ideal body weight. If the actual volume is equal to the target volume, the pressure support or the IPAP will stay the same. However, as you can see moving along this, the target volume is now higher than the actual volume of the patient. And in order to achieve our target volume, the pressure, the IPAP, is increased. So very much similar to the other algorithm that I've just explained. If the target has not been met, the inspiratory positive airways pressure will increase in order to try and achieve that target volume. And what I personally do is I ensure that my maximum pressure support or my IPAP max is at least 10 centimetres of water higher than the minimum pressure support or the IPAP minimum, because we want to have a good range in order for us to be able to achieve the target volume. Now, when it comes down to working out what the target volume is, there are plenty of graphs that you can look at and tables to work out what your ideal body weight is and what the target volume is at 8 mils per kilo. So if, for example, if I was going to ventilate myself, my height's around 165 centimetres. My ideal body weight will be 64 kilograms. And therefore you would set a target ventilation volume of 510 mils. Now, that actually might be a little bit too much for me. I don't quite weigh 64 kilograms. And so if you look at your patient, you need to make a decision about, are you targeting at that, or do you need to just go that little bit lower because they're not quite at that body size and out of the natural range. So if we look at auto titration modes, and this is an example of how the Breas auto titration mode works, what we look at is our measured tidal volume versus our target tidal volume, and that's no different to anyone else. But there are parameters set within the algorithm that looks at the actual volume delivered, and is that less than 5% of the set target volume? And if it is, the algorithm will increase the IPAP in 0.5 centimetres of water and keep sampling until the target volume is achieved. When the measured tidal volume is equal to the target volume, there will be no change in the IPAP. However, if the actual tidal volume is greater than 5% of the set target volume, so if it's 5% or more, it will decrease the IPAP in 0.5 centimetres of water units until the desirable target volume is met. But it's really important not just to dial in a target volume and not look at the ventilator download and your data. Because what I know one of the common mistakes, and I'm sure you guys are not going to do that, but when we initially had target volume modes, we would put it in, we would calculate what we were achieving, and then we would do a sleep study analysis. And we may find that the patient is still hypercapnic. And in that instance, what we were doing was we were increasing the targeted volume or the alveolar ventilation that we wanted without actually looking at the download. And it is important to look at the download, because if we have a look here, I've highlighted our pressure and our volume that the patient is achieving. And this black line here shows what we're measuring. So at this point, our actual volume that has been delivered is 472 mils, and that is at a pressure of 16.21 centimetres. Now, when we look at this, our maximum pressure is 16 centimetres of water. So in order to deliver 472 mils, our ventilator is delivering a maximum pressure of 16 centimetres of water. However, our actual target volume is 600 mils. So the device is unable to achieve that target volume with the pressure that has been set. And so it's important to look at your summary data, look at your download data, and make sure that you have given enough of a window for your target volumes to be met. Let's talk about auto EPAP for a little bit. So auto EPAP is an algorithm that's intended to automatically adjust the EPAP, and it's to maintain upper airway patency. And it's during non-invasive ventilation, and it's typically in adult patients. We have two ways of doing this. We have the forced oscillation technique, which works by comparing a shift of small amplitude oscillations on a flow signal to the oscillations on the pressure signal. And these measurements are taken at the end of exhalation over 10 breaths. When we see a higher resistance, it indicates upper airway obstruction and the EPAP increases. Other algorithms look at a detection of a reduction in flow, and that they will adjust the EPAP accordingly. Now, for both of these algorithms with auto EPAP to work, you need to have a good mask seal with minimum mouth leak in order for it to be able to detect accurate expiratory volumes. And some devices require that you use a leak circuit for this. So let's just look at an example of how a flow reduction auto EPAP algorithm may work. So it's looking, as I said, instead of looking at the oscillations, it's looking for a detection in the reduction of flow. And it will be classified by various different ways. So if there's a flow reduction in this example of 10% over 10 seconds, a flow reduction below 10% over 10 seconds, it's classified as an obstructive apnea. And depending on the device, it will increase the EPAP in a certain amount of pressure over a period of time, but it happens after the event has finished because the airway is closed. There's no point in it trying to increase the expiratory positive airways pressure in this situation, and it works to prevent it happening again. If there's no flow reduction, but a lack of effort, that is not an obstructive apnea. That is a central apnea, and the EPAP won't change. If there is a flow reduction, and in this situation below 70%, for example, over 10 seconds, an algorithm will determine that that is a hypopnea, and it will increase the pressure at whatever the algorithm is set to in order to prevent that hypopnea becoming an obstructive apnea. The airway is still open, it's narrowed, causing the reduction in flow, but it's not closed. So it will try and prevent that turning into an obstructive event. And that's how auto-EPAP algorithms work when they're looking at a reduction in flow. So let's just have a little look schematically at how standard pressure support and auto-EPAP looks. So here we have our flow trace in red, and you can see we're going along and we have no flow. Therefore, that is classified as an obstructive event. Flow returns after the event. And what happens with flow detecting algorithms is that the EPAP will stay the same during the event, and it will increase after the event to prevent the next event. But the pressure support will also increase. So you'll find that there'll be an increase in the IPAP, and that will be of the same magnitude as the previous setting. So it will always deliver the same pressure support, but there will be a higher EPAP and a higher IPAP. And that will be between whatever you have set as your minimum EPAP and your maximum EPAP. Let's look at hypopnea this time. So we have our flow trace. We have a reduction in our flow, but the airway is not closed. So during this event, the EPAP will increase. The pressure support also increases. So the EPAP and the IPAP will go up, giving the same pressure support for here and here. And it stops the airway closing. And looking at the central event, here we have the flow. You can see that there isn't a reduction in flow. There is a lack of effort, but the flow is within the normal range. The EPAP does nothing. The pressure support stays the same. And of course, we don't want to keep people at a higher level of EPAP than they need, because this could induce mask leak. It can be uncomfortable having a high level of EPAP if you're in a lighter stage of sleep and you don't need it. So when there is a resolution back to normal breathing, and that can be depending on your device set and the algorithm between a various period of time, but after the set period of time, with normalization of breathing, the EPAP will drop, and it will then resample and see whether it can drop again. And again, it is really important to look at your ventilator software data, whatever device you're using, whatever make you're using. So here we can see there's a little bit of a movement. It's fluctuating a bit, but we start to get into a period of stable breathing. And here we have the patient flow and the total flow, and there is a reduction compared to over here. The device has said that there is a hypopnea, and you can see it's increasing the EPAP during the event to try and keep the airway open. The airway is open, there is a resolution of normal flow, and the device has carried on. But the key thing about this is that the maximum EPAP was set at 10 centimetres of water, and you can see it's sitting at 10 centimetres of water here, but it may need a little bit more. And so afterwards, you may decide that you want to, based on your ventilator download, increase your maximum EPAP pressure higher than the cutoff of 10 centimetres of water in this scenario. Okay, let's look at what happens with a targeted volume and a auto EPAP algorithm. So in addition to our pressure traces that we had in blue, our flow trace that we had in red, we now have a volume trace. This is the same example that you saw with the obstructive event. Now, as soon as the airway is closed due to obstruction, you will see a decrease in the volume that the patient is achieving. Now, because there is a reduction in volume, the first thing that kicks it in is the targeted volume algorithms. And so you see an increase in your pressure support because it wants to try and give more air to get the volume to be up at the target. The EPAP algorithm kicks in after the resolution of the event. And what you might find is that the EPAP stays higher, but your pressure support comes down, your IPAP max comes down because you have achieved your target volume. They're working independently of each other. In a hypopnea, again, you start to have a reduction in flow, which leads to a decrease in your volume. In kicks the target volume algorithm and increases the IPAP. But rather than waiting for the termination of the event, the airway is still open, so the EPAP algorithm will then kick in. And during a central event, we can see that there is a reduction in volume with the central event, but no reduction in flow that would indicate upper airway obstruction. So in this situation, the EPAP stays the same, and it is just the target volume algorithm that is changing. So why would we use target volume or auto EPAP, or both together? Well, when we think about it, what we think about with target volume, or what I think about, is why would I want to use it? Well, it may be that I want to be sure that if a patient has changing lung compliance throughout the night, for example, with COPD, that I want to make sure that they're adequately ventilated. And likewise, if they've got a change in their chest wall compliance, for example, due to obesity, and that can change depending on what position we're sleeping in, I would want to accommodate for that. And I know that I might need to give different levels of pressure support to adequately ventilate and maintain an optimal volume for that patient. And what we also see is that there has been hesitancy around what settings are optimal for patients. You might look at a patient and you think, God, I know that that patient needs an IPAP of this and an EPAP of that. But there are some we look at and we think, oh, I really don't know what setting to give, or that there may be some educational barriers and experience barriers about titration of settings, and having this freedom to dial in a number and let the ventilator take over can be an option. So the way that I would look at it, though, is if I'm going to use the target ventilation mode, I want to do it to maintain adequate tidal volumes regardless of chest wall or lung compliance. And when it comes down to EPAP, I've alluded a little bit earlier, but EPAP is used to maintain upper airway patency, but it's also used for lower airway recruitment for atelectic areas, to improve oxygenation and to overcome intrinsic PEEP in COPD patients. But I just want to reinforce once more, auto EPAP algorithms, whatever company or manufacturer that is device you're using, is to maintain a patent upper airway. So we have this multifactorial thing that is going on, and if we combine the two together, the way I look at it personally is that auto EPAP and target volume, I'm ensuring that I have a patent upper airway and that I'm dealing with changes in lung or chest wall compliance. So I've explained why I would do it, and when we look at the publications, there's a theme coming through that there is no optimal setup for home non-invasive ventilation that's well established. Everyone does their own thing within their own protocols and their own reason. But evidence suggests that whatever we are doing with regards to non-invasive ventilatory support, we need to control nocturnal hypoventilation, so overnight carbon dioxide levels. And this is required for patient benefit in terms of survival, decrease in symptoms, and improvements in health-related quality of life. I think that we probably historically hadn't paid enough attention to detail around EPAP, and we need to have careful consideration with regards to EPAP, particularly maybe in COPD patients that are at risk of coexisting obstructive sleep apnea, and the treatment of this can be challenging. We know that fixed level CPAP can have adverse effects on pulmonary mechanics in patients with upper airway obstruction. That was shown by Martin Tobin and Gerben some years ago. So using target volume with auto-titrating EPAP could be a helpful solution. Now, this is an interesting study looking at home initiation of a target volume mode with the conjunction of auto EPAP. And what they did was they had a group of COPD patients that they commenced with home non-invasive ventilation along with home monitoring, 2 to 4 weeks post-discharge. So it met the hot HMV criteria of them remaining hypercapnic post-exacerbation, or in those patients they set up who had persistent hypercapnia that didn't resolve. And what they did was, this is their remote monitoring setup. So patients as an inpatient had transcutaneous carbon dioxide, blood gases and NIV titration. They had early discharge and then they were reviewed 1 to 2 weeks after. Now, depending on their results, they were set up as a day case at home or in a referring hospital as an inpatient. But they had a face-to-face or a postal supply of the device, mask and a video call around the setup. And what was interesting is when you look at their protocol for setting up, they used a targeted alveolar ventilation mode, aiming to target around 8 to 10 mils per kilo of ideal body weight, and they had the auto EPAP on. And what they did was, depending on the results and the information they received, they increased the settings. So this was a pretty generalized approach that they sent the devices out, and that the team would not detail manually titrating. And what they showed was that they had a reduction in their carbon dioxide levels on average of 2.2 kilopascals after the provision of non-invasive ventilation in a group of patients that remained hypercapnic sometime after their exacerbation, so they didn't naturally resolve. They had a decline in their bicarbonate levels, and when you look at time to readmission or death, the NIV group had an improved survival or lengthier time to readmission compared to non-NIV users in this dotted line and a control group. So it's really interesting use of target volume and auto EPAP. Let's just take a look at different diagnoses and the evidence base. So if we look at central hypoventilation syndrome, this small study by Reshma and Min's group in Toronto looked at a group of children with central hypoventilation syndrome, and they had 8 in IVAPS and 8 in spontaneous times mode, and they compared sleep quality with regards to total sleep time, sleep efficacy and REM, arousal index, all of the normal stuff you would expect. And what they found was that there was only one significant difference, and that was in their non-REM peak transcutaneous carbon dioxide levels. There was a tendency, although it didn't reach significance, for an improvement in sleep quality with the IVAPS mode. So they had decrease, but there wasn't any differences in adherence, which is shown in this table here. The same group looked at volume assured pressure support in a group of patients with neuromuscular disease. So slightly different population. And they looked at ST mode versus volume assured pressure support. And what they found was that there was a greater adherence in the volume assured pressure support compared to the spontaneous times mode, with regards to hours of usage being more than 4 hours per night. And also the average and median use was higher. However, when we look at the sleep parameters, there was no difference between the ST mode group and the VAPS group. And patients did not report any significant difference in comfort between either of the devices or modes. Let's look at target volume in COPD. And what I'm not going to do is I'm not going to go into every single study in massive amounts of detail. You can have a little look yourselves if this is an area of particular interest. But when target volume was compared to high intensity non-invasive ventilation, no difference was found in a group of patients who had high intensity or target volume. But the patients reported for the target volume that they had a more restful sleep. If we look at target volume in ST mode, with IVAPS, you were able to deliver higher inspiratory positive airways pressures without affecting sleep quality. There was no difference in outcomes between target volume and pressure support with regards to adherence or other ventilatory parameters in a COPD group. And there's been shown to be no change in patients with an acute exacerbation of COPD. There was a meta-analysis with regards to standard pressure support versus targeted volumes that was published in 2020. And that again said that they had a similar efficacy, but target volume could significantly improve the patient's subjective feelings. So patients may feel better or that their sleep quality is better for using a targeted volume mode. If we look in sort of a mixed obstructive and restrictive population, Julia Kelly showed that target volume was effective as a manually titrated pressure support in controlling nocturnal hypoventilation, but there was a better adherence in patients with the targeted volume mode compared to the standard ST mode in patients that were naive to non-invasive ventilation. Target volume and pressure support seemed to have similar efficacy in improving gas exchange, but patients have reported the average adherence between the two groups was excellent and that there wasn't any difference. When we look at target volume in obesity, there's been no difference shown for target volume and fixed level pressure support in one study, and in another they felt that target volume provided the additional benefits on ventilation quality as there was a more efficient decrease in the carbon dioxide levels. However, there was no clinical benefits with regards to sleep quality or health-related quality of life in that study. A more recent study looking at target volume in neuromuscular disease, and this was in particular ALS, they showed that compared to IVAPS and ST mode for adherence at baseline, which was 1 week, that more patients were using it for more than 4 hours in the IVAPS group compared to the spontaneous timed, and the average daily use was higher. However, this was not sustained at 1 month, and there was no significant difference at 1 month or 6 months. Auto-EPAP on its own has been shown to be non-inferior to ST mode with AVAPs, but some patients found it more comfortable. When we look at auto-EPAP and target volume combined together in COPD patients with chronic hypercapnia, the addition of auto-EPAP to auto-titrating target volume led to a decrease in carbon dioxide levels, improvements in tidal volume. There was a decrease in unintentional leak. Patients felt less breathless, and they reported that they were more comfortable with that mode. And looking at a COPD and obstructive sleep apnea overlap population group, which 30% of the patients fitted into that group, who received 1 night of target volume and auto-EPAP versus 1 night of target volume with a manually titrated EPAP. The auto-EPAP led to a decrease in the ODI, less light sleep judged by stage 1. There was a decrease in arousals. There was an improvement in REM, rapid eye movement sleep, which is what we want. And so they concluded that auto-EPAP was significantly non-inferior to manually titrated EPAP, but it didn't result in improvements in gas exchange. So looking at it, the way that I would summarise target volume on its own is that it improves patient comfort, and it may have a greater effect on carbon dioxide reduction. But if you combine target volume and auto-EPAP, you may find that you get additional benefits. So probably using the two together is more beneficial than using them separately. So there's an improved patient comfort, there's a decrease in unintentional leak, there seems to be an increase in patient usage and an improvement in sleep parameters. But I think at the moment the evidence is still gaining, and if you want to use standard pressure support modes, that is still absolutely fine. So when I look at my patient, I would do what I'm most comfortable with, and that's what I advise you to do. If you are a manually titrating person, you will get the best results out of your patient doing it that way. If you prefer auto-titrating algorithms, again, you may find that that is more beneficial for you. So you can either set a pressure support with or without auto-EPAP and adjust according to your overnight results. And if no matter how much you have tried to titrate and improve things, you are not getting the outcome you want, you may consider swapping to a target volume mode. Likewise, if you start in a target volume mode with or without auto EPAP, and as I said, I would probably favour using auto EPAP with them, then if you don't get to where you want to be and you can't improve gases, then look at swapping into a standard pressure support mode. So do what you're most comfortable with and you'll get the best out of your patient. Should you be watching this on catch up, this is my Twitter address and you can always direct message me should you have any questions. So I'm going to get rid of my laser pointer so that I can stop sharing. Have a little look if we have any questions in the Q&A. So please just give me a moment while I load that up. Lovely. Okay, so, takes me a while to just read it. There's a really interesting question here around using target volume modes in children. Now, I think it's really important to bear in mind what the companies have done with regards to their target volume modes, whether that's AVAPs, IVAPs or target volume. You need to have a little look at what the licensed use is, and there will be a set weight that it is recommended that that mode is used above. And the reason for that is that the algorithm has been tested in individuals above that weight, and children will have smaller volumes than adults. So you can't necessarily guarantee that the algorithm will work in the way that it should do. So by all means, you need to evaluate your patient. If you can't manage with standard modes, then you need to do a risk analysis and say, does my patient really, really need this mode or not? And if they do, justify why you're going to be using it in the way you can. You could also look to looking at if there are any devices out there that are licensed for use in the weight of your child and potentially use that. So that's a really, really interesting question, and one that quite often clinically, when the team are discussing someone, we need to pay attention to detail about. Okay, looking at the next question, are there any contraindications to using automated modes? Again, a really, really good question. And my answer to that is that the contraindications to using these modes are exactly the same as non-invasive ventilation. I don't know of anyone that has added a different contraindication into it. However, personally, I would be extremely cautious about using auto-titrating modes in individuals with bullous lung disease, those that are at risk of pneumothorax, just because I don't know if that maximum pressure support or maximum IPAP that I set is going to tip that individual over and cause further lung damage compared to what they have. So it would be about, if you did want to use it, I would set a very tight window for my IPAP. And then am I really giving an automated algorithm, or am I just allowing something to move around a very small window? The other thing I would be cautious about is that some of the algorithms work on looking at minute ventilation. One thing that we need to bear in mind sometimes with neuromuscular patients is that they can increase their minute ventilation by increasing their respiratory rate. So you may be achieving your minute ventilation overnight, but the patient has done that by increasing their respiratory rate. And I've had a few patients that I've taken off ventilatory support after trying a targeted volume mode that have done this, and that they felt absolutely exhausted in the morning. So just have a think about what device you're using with that patient, and what is the method of it trying to achieve the volume that you want. Okay. Oh dear. Oh, always one person asks this question. Is there any evidence to say that one company's algorithm is better than another? And no, it's one of those things that if there's anyone out there from the other companies, maybe they want to contact and we all want to get together and put money in the hat to do that study. So at present, nobody has done a study looking at different algorithms that aim to achieve a target volume and tried to work that out. So really, really good question. But I wouldn't necessarily do it. Okay. Lovely. So there's another question around paediatrics. Would I set 8 mils per kilo in a child, or would I use a slightly different setting? So I personally, I usually set 6-7 mils per kilo, look at the results and increase it if needed. For the same reason as I highlighted, it depends on where that child is and where their growth is. They haven't reached adulthood, and what we don't want to do is over-distend the lungs and cause lung damage. But it's also important that there are changes in lung volume to help lung development in paediatrics. So I tend to err on the side of caution, look at the sleep study results, and then based on that can increase it if needed. All right. There's one question which is really, really interesting, which is around using target volume in artificial airways. So again, it goes back to what is the license for your target volume? Is it a non-invasive mode, or is it licensed for both? And what I would do is I would use a device that is licensed for it if in an invasive mode, rather than those that aren't. The other thing I would say is just going back to which device and which algorithm may be superior. All I would say is if you've tried a targeted volume mode and with one device and it hasn't worked, there is no reason why you cannot use a different device that has a different algorithm, and you might find that that is beneficial for your patient. It's a little bit like chocolate. I'm trying to think of the chocolate that there is over in the States. So some people might like Hershey's, and some people might like, Cadbury's is the brand back here. We all have our favourites. It's all chocolate, but there may be one that is more appealing and more comfortable to us. I think I've probably taken up quite a lot of your time, and the questions, we don't seem to have any more that have come in.